Thank you, Dr. Akshay. Thank you, Dr. Chandrika, for inviting me to chair this very important session with Dr. Jayashree. We are coming to the almost last part of the cytokine release syndrome in children conference, which has been valiantly organized. And Dr. Akshay has opened a Pandora's box. We still have to do a lot of study to really know which patients will benefit from immune modulation and how to go about it. So I think we are at right time to now look at targeting cytokines in CRS. What are the future trends? What are the molecules that we will be looking at? What are the tests that we will do to justify use of these molecules? We have a brilliant speaker from Alabama in Birmingham, Professor Randy Cron, whom we heard yesterday during the case discussion on dengue, giving his very valuable comments. He focuses on the study of heterozygous mutations in familial HLH and novel genes which contribute to the CRS cytokine storm syndrome. As you can see from the slide, he has got a very distinguished career, starting from his pediatrics residency at the Stanford Children's Hospital at Palo Alto, University of California, MD, a PhD in immunology, a postdoctoral fellow from Stanford again, a pediatric rheumatology fellowship, a National Institute of Health Bethesda scholar, and a BS in biomedical sciences. So I invite Professor Randy Cron to tell us about the future trends as far as cytokines in CRS.
Thank you very much for the invite. Can you tell me if you're seeing my full slideshow or my...
Yes, it's full slide, sir, and excellent. You're audible.
Excellent. All right, thank you. And again, thank you for the invite. This is, like Dr. Khan and others mentioned, this is a really a great forum. I do have some relevant disclosures. And I'd like to talk about some of the pathophysiology of disease before I get into the meat of the treatment, which we've heard a lot about already today, just because I think it does inform what choices of medicines we may employ. But I'll start with the case. And actually, this was the patient that got me very interested in this and shifted my research focus at the time. So I was in Philadelphia at the time, and this was a 14-year-old girl who came to us with a prior diagnosis of cytophagic histiocytic paniculitis, something I'd never heard of and hope to never see again. And she had been diagnosed at a young age, and unfortunately for her, she suffered fevers every single day, high fevers. She had total body paniculitis and lipoatrophy. She really had no fat. And she presented to us with belly pain and a large liver on exam. And even though she was 14, she was really the size of an average 7-year-old. We surmised either from chronic steroid use over the years and or just chronic undertreated inflammation. And seeing the word paniculitis in her diagnosis, we started her on cyclosporin and glucocorticoids, and she got a little bit better, but unfortunately she was back to our hospital within a month, except this time she was admitted with abdominal pain, and she seized and was comatose and got moved to the intensive care unit. She had inflammation in her cerebral spinal fluid and in her blood. She was coagulopathic, pancytopenic, hyperferritinemic, and quickly progressed to multi-organ system failure. So she was on, I think, 3 different inotropes to support her cardiac function. She was an ARDS. She had renal failure, liver failure, pancreatitis. Her cell lines were in the toilet. She was bleeding from multiple orifices. For me, actually, she was one of the sickest kids I've ever seen, who eventually came out of the ICU essentially unscathed. This was her bone marrow at the time, and it showed the classic hemophagocyte. We got this in retrospect. This was at 9 months of age. This is her fat that's infiltrated by all these lymphocytes that do not belong there. And despite the fact that the HLH-04 criteria are many times far too restrictive for secondary forms of cytokine storms, she was sick enough to meet these very easily. And I won't belabor them because people have talked about these quite a bit. They initially had called the hemato-oncologist, this is back in 2004, because they had a protocol for treating cytokine storms like HLH. And she was started on etoposide. They increased her cyclosporin dose and put her on dexamethasone as part of the HLA-HL4 protocol. But she was actually clinically worsening, and her labs were getting worse as well. And they realized that we had seen her earlier as an outpatient. And so they called us, Ed Behrens and I, who was my fellow at the time. And this was around the time in 2004 where we had started as rheumatologists using the drug anakinra to treat children with systemic juvenile idiopathic arthritis, because it was really a game changer for those kids. And because many of those children with systemic JA will develop MAS or a cytokine storm, we reasoned this girl was going to die. I was pretty convinced of that. We were all pretty convinced of that, that we could try IL-1 blockade because it might help. And we talked to the family, obviously, we talked to the rest of the team and decided to go forward with it. And within 2 days, she woke from her coma. Within 6 days, she was out of the intensive care unit. She was out of the hospital within a couple of weeks. And it was really nothing short of miraculous just by adding anakinra to her therapy. And so as a kind of a generic understanding of what we think is going on for a lot of cytokine storms is shown here. So on the y-axis, we have the generic strength of the immune response with time marching along the x. And let's say you're a normal host and you get an infection, could be influenza, for example. Your immune system will hopefully mount an appropriate response to that infection, begin to clear the infection, and then your immune system is actually hardwired to shut itself down. Otherwise, we'd be one giant lymph node, like an ALPS patient, for example. But what's thought to occur in many of the cytokine storm syndrome, including HLH, is a defect in the ability of your natural killer cells and your cytotoxic CD8 T cells to kill off these infected antigen-presenting cells. And that results in a prolonged engagement. And this was modeled by Michael Jordan, the pediatric hemato-oncologist, not the famous basketball player, when he was in Pippa Merrick's lab in Denver, Colorado. And what Mike did was he took wild type or normal genetic mice and compared them to mice that were homozygous, deficient in perforin. And these perforin deficient mice are perfectly fine in the mouse colony until they get the wrong infection, in this case, the LCMV virus. And the wild type mice, the CD8 T cells will recognize these infected antigen presenting cells. They'll begin producing pro-inflammatory cytokines, including interferon gamma, and they will kill or lyse these cells and shut down the viral life cycle. And they clear the virus and they do fine. The perforin deficient CD8 T cells, they will also recognize the infected cells and produce interferon gamma, but they can't kill. And these mice uniformly die within 10 to 14 days. And that's a great story. And if he had stopped there, it still would have been a great paper. But what Mike did, and we've seen this data somewhat already in this conference, is he blocked either the CD8 T cells in these perforin deficient mice that were infected, or specifically blocked interferon gamma. And you can see how that prolonged their survival. And this is a really important concept. And I think something that all clinicians need to know, because we're recognizing the breadth of cytokine storms in general. And that is, the virus here was the trigger of this hyperinflammatory immune response, but it was the host immune response that was killing the mouse, and similarly what we think occurs in humans. And so in addition to perforin, there are a variety, and we've seen some of this already in this conference, of these familial forms where you're homozygous deficient in any of these proteins that are important for perforin to do what it does. And that's shown in this cartoon here. So on the left, we have either a natural killer cell or a cytotoxic CD8 T lymphocyte. They share the same pathway. And perforin is pre-existing in these cytolytic granules along with proteins like granzymes. And when this cell recognizes its target cell and becomes activated, these perforin-containing cytolytic granules will traffic along the active cytoskeleton to this immunologic synapse between the cells. And all these funny named proteins, RAD27A, Syntax11, MUNC13.4, et cetera, they're critical to this process to occur. And then perforin will get released and form a channel or pore between these cells, allowing for delivery of granzyme, which triggers this apoptotic cell death. And here's another really important paper, and there have been confirmatory papers since then from other groups, that Misty Jenkins and colleagues in Australia performed. And what she did was she took human or mouse, CD8 T cells or NK cells, didn't matter, granzyme deficient or perforin deficient, didn't matter, and observed the interaction by time-lapse imaging. And what she found is if you were defective in this perforin-mediated lytic pathway, that the time spent between the lymphocyte and its target cell was 5 times longer. Okay, great. What does that mean? Well, that results in increased pro-inflammatory cytokines such as gamma interferon or TNF, which are thought to lead to the eventual multi-organ failure that is associated with cytokine storm. So this is kind of direct evidence that this lack of killing contributed to this pro-inflammatory cytokine storm. And we've all seen this multiple times as well, so I'm not going to belabor it. But there are multiple pathways to get here. And I think, as Scott and others have pointed out, this is really important because they're not all the same. They share many common features, but there are multiple ways to get there, including high levels of IL-18 and interleukin-1 in diseases like systemic GAA or NLRC4 mutations. There are these familial forms, which is maybe 1 in 50,000 live births, so not that common, that gamma interferon is obviously very important. There are these iatrogenic causes like BiTE and CAR T-cell therapy for refractory leukemias and lymphomas, in which IL-6 and probably IL-1 is also very important. And then there's a whole slew of different infections we just heard about, dengue being one of them, that there are probably going to be different types of therapies in addition to treating the virus that you're going to go after. So I think it is important to know the pathophys of what's going on before we come up with our chosen therapies. And so this is kind of the outline of what I'd like to talk about, with most of the focus being on the biologic therapies. So early on, even in rheumatology, we realized that glucocorticoids could save lives in these children, and these were many small case series, so not great data, but the kind of the best we had to go by. And then many of these were children with the systemic form of juvenile idiopathic arthritis who were dying from this hemophagocytic syndrome with sick livers and pancytopenia and hyperferritinemia, and steroids could save their lives. Cyclosporin, and I've heard many people say this, and maybe I just am not aware of this. I actually used to study NFAT transcription factors quite a bit, and that's how calcineurin inhibitors like cyclosporin and tacrolimus and voclosporin work, is they keep the NFAT family of transcription factors from translocating to the nucleus to turn on a variety of cytokine genes, including many pro-inflammatory cytokine genes. So I think these drugs work actually very quickly. So I'm not sure why there's been a lot of talk about them not working quickly, but nevertheless, they do also help. And so even in patients that weren't responding to steroids, or if they just gave this drug, cyclosporin in this case, that also helped survival in children, primarily again with systemic GAA. We've heard a fair amount about dexamethasone and etoposide in the HLH04 group, and Jan Ingehenter and his colleagues have been instrumental at putting this out there. And that was why that initial patient got treated with that, is because they have these prospective, they're not randomized, but these open label trials to study this, and to their credit, they have. Most of the data is again on secondary forms because the familial forms are much less common. But even back when this was published, 55% survival is not great. It's gotten somewhat better than that. But again, this data is from places that know what they're doing. So in places that don't see a lot of this, this is still a pretty dismal survival. And I won't belabor the protocol. IVIG, I've said previously in this conference, anecdotally, I haven't found it helpful. I don't find it harmful. If it helps, great. The only thing you might want to do is get some serum set aside before you use it, because that will be complicated by using IVIG. But people have reported case reports and case series that it helps in various infection-triggered cytokine storms. ATG hasn't got a whole lot of attention. Removing all your T cells is a pretty dangerous thing, but if you're dying, as shown in this case series, it can help. There are other ways to go after broad immunosuppression as well. And we've heard a fair amount already about plasma exchange. This was a case series, again, not perfect data, but again, suggesting that, removing evil humors, in this case, maybe pro-inflammatory cytokines more than anti-inflammatory cytokines, can benefit patients with cytokine storms. Rituximab, an issue is going to be a great drug for Epstein-Barr virus associated, which is one of the most common triggers outside of, I guess, things like dengue of cytokine storms. And early on, it was being used in patients with X-linked lymphoproliferative disease, and actually helps there. But it didn't broadly help others who didn't have X-linked lymphoproliferative disease, who had Epstein-Barr virus-driven cytokine storm. So it hasn't panned out as well. But if you have the ability to tell if it's in other lymphocytes besides your B cells and it's not, then it seems like a reasonable approach to target the cells that are infected and that may be contributing to the cytokine storm directly themselves. So we heard about, this interaction and this broad expression, in the debate, why is it that targeting individual cytokines makes sense? It doesn't make sense to me, but we also heard about just kind of keeping this balance concept. And to me, your immune system is pretty good about balancing things. And at some point you get over this threshold, if you like the threshold model of disease, where you can no longer balance out the pro-inflammatory situation. And so it is surprising to me, but anecdotally, we know that anakinra works, for example, in that first patient. So it may not even be the central cytokine to the process, but targeting individual cytokines can work to get the balance back in order. So as crazy as it may sound, it is a reasonable approach. And we also heard that, TNF inhibitors have been in case reports and case series reported to cause. It's very hard to prove cause and effect. They're giving the TNF inhibitor because someone is really sick, for example. But some have clearly helped. But in general, it may not be the first drug you go to until we get a better idea of what situations where TNF is really one of the major players in the problem. But again, for us, particularly from a rheumatology standpoint, when IL-1 blockade was being used to treat children with systemic JA, which prior to that, we were really dependent on steroids, which is a horrible thing to be on long term. These kids were miserable. And when Virginia and colleagues in Dallas reported on this cohort of 10 kids who were sickest of the 6 systemic JA kids that they had, and they just all did great on anakinra, this became just this new wonder drug for these kids. And you've heard me already talk about it, but these are some of the reasons why I really like this drug in general. So again, it's a recombinant human protein. So it's not some toxin or poison. It's something your own body makes. And really you're giving just excess to balance out the IL-1. It's not that you can give endless amounts of insulin, for example, which is another recombinant protein, but here really all you're doing is balancing IL-1. It's very fast acting. So if I use it particularly early on, before things get way out of control, I give it 48, sometimes 72 hours before I kind of give up on it or think of even considering increasing it if I'm getting a partial effect. So it's fast acting, that's important. It's got a very short half-life. So even if it was dangerous, and it rarely is, and I've heard a lot of people talking about even, not giving immunosuppression or immunomodulation and worrying about immune paralysis. This drug is not one of those drugs. This is not equivalent to cyclosporin. It's not equivalent to steroids. This is not equivalent, certainly, to etoposide. It just is not that powerfully immunosuppressant, but it's important if IL-1 is a major player in what's going on. It binds both IL-1 alpha and IL-1 beta, and in some diseases that matter, and some not. So the antibodies are not going to work that way. They're only going to bind beta, for example. And probably in COVID, IL-1 alpha is important with the endothelial damage that goes on there. And it's got a ginormous therapeutic window. There are very few drugs, if any, outside of a few of these biologics that target individual cytokines that you can 20 times the normal dose and get more benefit without more side effect. I mean, it's just a concept that most people are not familiar with. And it can be given either sub-Q or IV. It's probably better given IV if you can do that. But for example, Ebola, another hemorrhagic fever virus, many people died in 2014 outbreak in parts of Western Africa that were remote because they didn't even have IV access. And if that helped for this disease, I tried to push Tony Fauci to use it, but it didn't get too far. But it may ultimately have a role there as well. And then after our case report, this was a case series that Päivi Matunen put together. Ed and I contributed a couple patients to it. And these were kids who were rheumatologists. These were kids with primarily systemic JA and a few vasculitides who were not responding well to high-dose steroids, intravenous immunoglobulin, cyclosporin, and a few kids that also got started on the etoposide pathway. But again, anakinra fixed this small cohort of kids. And then everyone has talked about this, so I'm not going to belabor it, but even in the setting of severe sepsis, anakinra can help those who have features of a cytokine storm. So it's not a diagnosis of exclusion. I think that's also very important. And people have already reported on this too. So I won't belabor this. Other than to remind people what people have already told us is that the earlier you treat, the better. And so again, with a drug that's not powerfully immunosuppressive, I have no qualms about using this early. And again, really all you're doing is with this drug is balancing out excess interleukin, whether it's IL-1 alpha and or IL-1 beta, and its ability to bind its receptor and signal through that receptor. Other potential cytokines in the IL-1 pathway include the alarmin interleukin 33, which is an IL-1 family member. And I think Ed Behrens is continuing to push this forward, but in a mouse model, he showed that blocking the receptor for interleukin 33 could prolong survival of these mice. Scott and Ed reported on a patient with one of these autoinflammatory NLRC4 activating mutations, in which anakinra helped, but it wasn't enough. In this patient, like in subsets of patients with MAS, had very high IL-18 levels. And so IL-18 binding protein has a very similar role as an endogenous protein, again, much like anakinra serves for IL-1, IL-18 binding protein helped save this child as well. And so my guess is that various versions of IL-18 blocking agents will become part of our armamentarium as well. We've heard about CART and BITE therapies, iatrogenic causes of cytokine release syndrome in patients who were going to die from cancer. And so these therapies saved them from that. But in about 20 to 30%, they developed this cytokine release syndrome. And IL-6, which is easily measured, I think was one of the reasons they went after it early. IL-6 blockade works very well for the patients in this setting. IL-1 blockade works actually very well too, particularly if you have central nervous system involvement. Emapalumab. So we're coming full circle here. Michael Jordan's mouse model. Now Michael is part of this clinical trial where they're treating primary HLH, the sickest of the sick infants who have homozygous defects in the perforin pathway, right? So this is pretty sick kids who may not need to go down the etoposide pathway. So this is impressive, and this will, I think, continue to get broader use, particularly in many of the secondary forms. Janus kinase inhibitors. So early on, Kim Nichols and colleagues really were championing Ruxolitinib. All these JAK inhibitors are not the same, and they're not as specific as they're reported to be, but they have relative specificities. Nevertheless, in this mouse model, perforin deficient mouse model, Ruxolitinib helped. And Kim has collected now, over 100 case reports and case series of people claiming that Ruxolitinib is pretty good in many different versions of secondary cytokine storms. And so these JAK inhibitors are somewhat intermediate between very broad immunosuppression with glucocorticoids or similar broad immunosuppression of cytokines with calcineurin inhibitors versus individual targeted cytokines like IL-1 or TNF or IL-6 blockade or IL-18, et cetera. These are going to block multiple cytokines based on how the receptors are coordinated for many of these cytokines and how these kinases are somewhat redundant in the various receptors that employ them. So glucocorticoids are great drugs. They have a lot of the side effects, and if you're worried about immune paralysis or you're worried about severe secondary sepsis, you have to take that in mind. But if the patient's dying, they can also save lives. And I actually do like the use of cyclosporin. You do have to worry about things like PRES, reversible encephalopathy. When I've seen that, just anecdotally, those patients have ultimately gotten better both from their PRES and their cytokine storm. Cytotoxic drugs, there's definitely a place for them in the severest of the severe. I don't start with them typically. So particularly for many of the secondary forms. And then we've just gone through, these individual cytokines or broader immunosuppression of cytokines with the Janus kinase inhibitors. And so we've come a long way. I mean, this is a new field really to medicine, right? So Jan Inge Henter and colleagues paper on etoposide wasn't until the mid 80s. The first gene that was reported, perforin, wasn't until 1999. That case report that I showed you, the first use of anakinra for cytokine storm, that was mid-2000s. We now have FDA approval for tocilizumab as part of cytokine release if you get it from iatrogenic causes. We have emapalumab FDA approved for familial HLH. And COVID-19, this is a PubMed for cytokine release, cytokine storm, MAS, or HLH. And actually, truth be told, it'd be way off the top of this map if I had gone for the last 2 years. But it's one of the other kind of benefits in the middle of this pandemic is it has gotten a lot of attention to cytokine storms, both the lay public and clinicians who may or not be that familiar with it. And I'm happy to take your questions.
Thank you, Dr. Randy, for a brilliant expose on the journey of cytokine inhibition. And the explosion of knowledge in the last few years indicates how it's probably going to move into clinical medicine at a much faster pace than we assumed. And I think in this conference, we have looked at some of the common problems we have, like dengue, where this may play a role, and we probably need to investigate a little more in detail. I don't see any questions here. No, there are no questions here. Only comments that it was a very excellent talk. So thank you very much, Dr. Randy.